Thank you, guys. I'm quite sure you're tired of hearing this voice, just as I'm tired of standing up here. So forgive me, but you have to endure it just for a very short while longer. Continue to eat, and most of us have our food served, and many of us are done. So this is a good time to start. Let me tell you what we're going to do. It should be fairly short unless you choose to make it longer. What we're going to do is we're going to go through, I'm going to ask each of the facilitators to come up and kind of provide a synopsis. Now, some of this you've already seen, but I've asked the facilitators to use their discretion, adding things, subtracting things that need to be included as we move forward. Now, then the next logical question is, well, what do you do with this? In the past, to be honest with you, we've oftentimes had great ideas that never really grow legs. They never really grow legs. We've got great ideas, and because of our perception that there's no funding or whatever, they just don't grow legs, and so they kind of die on the vine. There are a lot of good ideas, probably more than we can actually tackle, but I want to encourage you. Well, let me tell you what we're going to do, and then I want to give you a bit of encouragement. What we will do as a group, the core group, and the individuals who are interested in these areas will be getting together independently to flesh out some of these ideas. Which ideas are really viable, which can go, which ideas didn't we talk about, and so that's going to be fleshed out separately in hopefully face-to-face meetings here in the very near future, so that we can actually come up with some agendas for each of these areas. I would encourage those of you who haven't, or who have overlooked, or who don't contact, who have ideas and they don't make it to this list somehow, or these lists, please contact me. Let me know. There are lots of things that can be done. Some are unfunded mandates that are nonetheless quite doable. We're really happy to get behind these things and support them, provided it's a reasonable, rational idea that's feasible. So what you're gonna hear tonight from the 4 different groups are basically their sort of view of these discussions, a consolidated view of this. They're going to spend 5 or 10 minutes each, and you can ask them questions, and we can go kind of wherever you want to with that. So that's how it will go. Once they are done, I will come back up. We'll kind of take any last questions. I've got a few announcements, and then we'll close, and then we'll all go out and pretend that there's a bonfire out there tonight. Okay, so we'll just do it in the order of as these groups presented yesterday. So the first will be John Perfect. John, are you going to do this alone, or is David still here? David here? David here? Okay, good. Yay. Okay. They want you up here, but honestly, it's hard to see the screen from up here. So can we? Oh, there we go. Sorry. Here you go. This is your problem now.
So David and I have split it up, and we're going to talk about the speakers and the topics, and then we have 2 other slides that we're going to go into in a very superficial manner. But we split up, and I said I would do the first 2, and then David will do the second 2 and give his insights and various things. Because I think what was important here was we had some outstanding speakers telling a lot of principles, and I think we need to reemphasize those again. Sometimes it may be relevant to you, sometimes it won't, but I think it's important that you kind of understand where the field's at. And for Cryptococcus, I want to spend a couple minutes talking about tomorrow on the pathogen. I think what you saw in her talk was that the power of Cryptococcus is really a model organism, not just a model pathogen, a model organism that has incredible genetics, proteomics, has genetics, has incredible animal models, et cetera, and you can really ask really, really basic questions. Second thing is you can see that she presented her stuff as looking at the capsule, but she can move out to other areas, including the cell wall and other types of the cell machinery. So you can see how a basic scientist can take this and start to dissect it in very, very significant and very, very aggressive ways. The third thing I thought was that she elegantly described the tools that we actually have today with this organism. It's incredible. The imaging that can be done, the mutant libraries that are available, the proteomics that can be done, the metabolomics, the RNA sequence. She didn't even get into all the massive amount of structural biology that this organism is going through on various targets. The critical features she emphasized, and I don't want to emphasize, I think that you should emphasize this, is that bioinformatics and big data is an important issue. Networks and connections are important issues. And for us in the mycology field to have the ability to actually tap into that and bring in bioinformatics people and bring in biostatisticians is going to be incredibly important to try to dissect the complexity of these organisms. But the tools are there now to do that. I think she illustrated that. The other thing I'd say is, in my own feeling on these, the ability in Cryptococcus to have such robust animal models to be able to dissect the issues. And I like to say that the mouse, the rabbit, the zebrafish, the various things are not perfectly a human, but they do have a lot of tools there, and they can control a lot of the situations a lot better than the human situation. It's tricky, and I think there is a lot of relevance to the animal models and what you can eventually see in humans. I want to emphasize again that she put up there something that's an important thing, and it's for many of you as clinicians. People like tomorrow need clinical scientists and interact with for various types of things, clinical cases, strains, et cetera, because even though I have a love affair a little bit with H99, we got to move past H99. It's a big world out there with a lot of different isolates. And we got to have clinical data, we got to have genomic data, we got to have various types of omic type data, and we got to have the ability to merge this together with basic science people to really understand what's going on. We need numbers. We will continue to need numbers, and we'll come back to that in a moment about biorepositories. We need absolutely good clinical data. So again, for the clinicians and stuff like that, connect yourselves with these basic scientists. You are a big value to them. Trust me, you're a big value to them to be able to integrate the kind of clinical cases for all the specimens and get the specimens for these people that can look at it. And finally, we need to understand and control the host. And in a lot of ways, with the animal models, we can do that to a certain circumstance. In the human side, it's tougher. But that brings me to Peter Williamson. This is exactly the things that Peter did and talked about is exactly what needs to be done. We need to take the animal data into the human data, and with specimens and follow-ups and having the resources of NIH to be able to do these clinical studies, these immunology studies, is extraordinarily important. And I think with Cryptococcus, he has started that, and I would highly recommend, if you have interesting cases or various things, any kind of connections you can get to him, because he has the environment to allow you to dissect these type of infections. And personally, I do a lot of rounding on the transplant ID service. And I find it extraordinarily bad that I hardly know what's going on with the immunology of these hosts. The only way I know that it's really in bad shape is the kind of organisms they have coming out of them. And we need to have people like Peter and groups to try to understand what these things are in the human host that then can be taken back. And I understand Peter could use many, many more of these, and there'd be many, many more people looking at these things, but at least it gets a start to try to understand what's important and what isn't. I think Peter emphasized again on his lectures is something that I deal with day in and day out, and I suspect you deal with day in and day out, which is the yin-yang of immunity. I call it the Goldilocks paradigm of immunity. Not too much, not too little, got to get it just right, and only God got it just right. But the issues around have to deal with immune-suppressed patients and then immune reconstitution, and how you deal with that becomes very, very difficult. I think Peter emphasized how the steroids is the love-hate relationship with that, because sometimes it's what causes these infections, it's sometimes what can get people out of these infections. And I think he emphasized that very good. And then finally, if I give this over to David, I think he emphasized the host. He started with immune people that were apparently normal. I'd like to say, and David will talk more about this, as Sharon talked about the risk groups, I think they're changing right before our eyes with Cryptococcus. I may be wrong, but these drugs like Rutinib and things, these kinase inhibitors and various things, I mean, they are doing some really drastic things to these patients. And crypto can come up right before your eyes. We've had several cases with no inflammation. And then finally, I'm not even sure, like I mentioned before, that I'm not sure what I saw in this little outbreak of IV drug users is real or not. Maybe it's just there's so many IV drug users out there that the denominator is incredible. But to have 4 cases in 7 months in one area in West Virginia is pretty dramatic to me. And I think what we're going to see, and we need to keep a pulse on it, how these hosts may change. And I think Peter at least has they have identified some of the reasons for these people getting infections, like the anti-GM-CSF autoantibodies. So I'd like to say that with that kind of background, that's what I got out of these things, kind of the basic science of the host, the basic science of the organism. They have incredible tools. They're doing, I think, great work to understand these things, and for you to try to connect with them, you know who they are and what they're doing, will be extraordinarily important going forward.
All right, so my task was to sort of summarize the epi and some of the clinical data, and we'll talk a little bit more at the end on some of the ongoing clinical trials. But the epidemiology, I think one of, not just to specifically speak about crypto, but one of the things that really sort of reinvigorated the field was to actually have some burden of disease estimate that Ben Bark came up with and colleagues in 2009. And from that and really moving forward over the last several years, there's been sort of a better appreciation of what is the burden of disease, looking at Craig prevalence rates and HIV positive. And so that's been fairly well fleshed out, and we have a upcoming publication sort of as an updated burden of disease in 2015, 2016. But I think what Sharon really spoke elegantly about was particularly in the HIV negative population. And so from Peter Williamson's groups, work in the U.S., a third of the crypto cases in the U.S. are non-HIV, and so likely that and that varies, slightly worldwide. So in Vietnam, it's almost half the cases. In China, in Southeast Asia in general, a large proportion of non-HIV patients with potential immune defects. And to really understand the epidemiology, I think there's a lot more work that can be done, certainly outside of the HIV realm with what's going on, particularly in the transplant population, and thinking about interventions. And so the concept of Craig's screening these transplant patients, that she presented some data. You're talking about a 3% prevalence of disease. That's a fairly high prevalence, so that's 1 in 30 people potentially. And so if you're talking about screening with a $5 test, after you spent $100,000 for organ transplantation, or probably more, I'm not sure what the actual cost is. Thinking about, is there, we're doing tacrolimus levels and all sorts of immunosuppressant levels that are important, but for a disease that's fairly common, thinking about is there a role of cryptococcal antigen screening and other potential fungal screening for invasive mycoses in this population. So I think that's something that's certainly a lot of the people in the room can potentially collaborate on and work a little bit more on that. The clinical trial, Tom did an excellent job of really summarizing a lot of the data and advances that have been done over the last 10 years, and sort of big picture lessons, thinking about some of the other fungi that one of the things that really has been helpful in crypto has been the small phase 2 trials to test new combination therapies using surrogate markers where we can measure CSF, fungal burden, and do quantitative cultures and look at sort of rate of clearance. And so thinking about how we can do that with the other pathogens, thinking about whether it's the T2 time to negativity for candidemia, or thinking about change in antigen for histo or blasto serially over time, and thinking about surrogate markers where you can do a small clinical trial for 30 patients and test a novel therapy or combination of agents as sort of a proof of concept. And then if you have preliminary data, then you can go to larger funders to ask for phase 3 trials, or just be informative for the field in general. And so I think that's one of the things that's really been helpful for crypto, where we can generate some preliminary data that then you can justify a larger phase 3 trial, or just learn from that experience alone. So we'll talk about some of the ongoing trials, I guess, towards the end. But our next sort of session here was going to be kind of some of the topics that were identified during that discussion breakout session. I will turn it back to John.
So Tom and I are David and I are kind of tag teaming this. There were several things that Pete put up on the list when we were going back and forth on the discussion. And so David said, I'll do this, and he'll do the next slide. So you'll see this. He's giving me one little thing on the next slide. First thing is the isolates and specimen repository. Like a lot of people, we've talked about this a lot of times. Nothing really happens. I do think that over time we need to push for this type of thing. It's expensive. It will require getting clinical information. It will require big freezers. It requires some effort in some way to actually figure this out, whether that's done with the CDC or done with groups that are established and have freezers and various things that can do this. But it's a tricky business because you've got to have a lot of barcoding, various types of things to make sure you got everything right that you can ship out to other people. Despite all the difficulties in that and the cost of that, I think it should always be talked about, and it should be continued to be discussed, and hopefully maybe sometime have a group that can get together and try to do something to allow us, not just for crypto, but for these other organisms, to have repositories where somebody, whether they have a diagnostic test, whether they have an immunology test, whether they want to look at the virulence of the organisms and have a series for resistance. It still needs to be done, and it should be, I think, a high priority. On pre-transplant CRAGs screening, I have mixed feelings on that. As I mentioned before, somebody asked me that question, I don't really know what the incidence of disease actually is to really come up here and tell you you should screen your patients. My gut feeling is that if we do this type of thing, I wouldn't actually do the recipient. Many times these recipients have already been beaten to death with a lot of antifungals before they even got there. My experience has been the majority of cases have been coming from the donors. And so it might be worth having a kind of study, just look at prevalence, get that old lateral flow assay out there in the southeastern part of the United States and see exactly what's happening with our donors. What is the real incidence of CRAG positivity? So I think it's something potentially worth doing, talking to the blood banks and UNIS and all those others to actually see what it really is. Species determination. We will talk to her blue in the face about whether we should identify these organisms down to various genotypes, to various subspecies, cryptic species, et cetera, and whether it has any relevance to clinical manifestations, host outcome. I think you saw Sharon stuff when you put this thing together. I'm not against it. In fact, I would like to say that the organisms may be a little bit different in some way, shape, or form. But I'm still not convinced that we're going to do anything until we probably have them all set up. And I asked this question again. I haven't been down in the lab for a while, so I don't know. But I think the only way that we're even making any progress on this is actually to identify the organisms in the first place. And I think where that actually is going to happen is with the MALDI-TOF. I mean, it can identify Cryptococcus, gadii, and neoformans. Can it do the other cryptic species and stuff? I suspect it can. But is anybody doing that and actually doing it? Well, somebody's got to do that. It's got to make it easy to do, to actually see what these organisms are, and then to go back and clinically correlate them. Immune therapy, I think I'm always attracted by immune therapy, trying to do these things. You saw what Peter did. I don't know what he was doing with immune therapy. The steroids were doing all kinds of things, I think. But I think what he's done is laid some of the groundwork for actually understanding immune therapy and trying to figure these things out. As I listened to his talk yesterday, one of the things I was a little concerned about when I deal with these types of patients, particularly normal patients, and I do think they have iris or something like that, and they're not responding to the steroids, or maybe I took them off too early. Would I use an anti-TNF type drug to kind of secondary type thing? It's been used on patients. So Peter's starting to look at these things, and if I'm looking at that type of patient population, maybe that's not even close to be thinking that we should be using anti-TNF therapy in that type of group that has a macrophage type of defect in the first place. So I think I'm a little suspect today and concerned until we really, really have the human immunology down before we play with immunotherapy. Exposures related to acute infection, I think that was an important issue, which I think is probably true. We live and talk about reactivation. A long time ago at Duke, Roger Baker showed that there was definite reactivation in tuberculosis or in cryptococcosis, and surely there's been stuff during the AIDS epidemic, typing of patients coming to France from Africa. There's no question there's a lot of reactivation, but I think what they emphasized and what was brought up was there are patients that acutely get ill and patients that acutely get infected with cryptococcus, and particularly some that are immune suppressed and they can get overwhelming disease. The biorepository, again, it's kind of going with isolates repositories. There is a triad here. And I think whenever you could get this together, that's why you have freezers, minus 70 freezers. You've got to not only have the organism, you've got to have specimens. And I talked today, I think, we're talking about DNA and RNA, but serum, everything you can get, you need to get and put that away and categorize that, and also have behind that clinical information. If you take away the clinical information, you will miss these type of things, because as I'm going to tell you, if you think that organism may have very hypervirulence or various types of things that it may be about, it is a tricky, tricky business if you don't understand exactly what host you're dealing with. So that is an essential feature, I would say, to Pete and to the MSG. We've talked about it for many, many years. I think it still is something that should be a high priority in how we could fill up these freezers with that kind of information. And finally, serologies. Arturo talked about his serologies and the antibodies. It is low-hanging fruit. He's done it for a lot of years. I don't think he is wrong necessarily about understanding the host. I think it's still more complex than that. The cell-mediated immunity is important. And the organism, if it's really looked at very, very closely, there are circumstances that are different. For us, for instance, one of the things I think most of you guys work on or try to think about is the host when it comes out. It's a specimen, a clinical specimen. And I'm saying, well, yeah, that's okay, but actually that specimen's already got in the bloodstream, that specimen's already got to the CSF. I want to see these organisms back out in the environment before they even got there, because some way they develop tools and stuff like that they may be the good comparators that we have. And so I think you need just as much from the environment, particularly in these things, as you do from the host to really dissect this complexity.
So, and then we just kind of want to, this is our last slide, so we will try to be, we have try to be brief. Anyway, so it's kind of to review the sort of the potential studies, ongoing studies. So the sort of the current ongoing studies that are presently funded. So there's basically two non-inferiority trials that are going on, and so one is the ACTA trial that Tom Harrison is leading, and so that is looking at sort of 7 versus 14 days of therapy and the role of sort of adjunctive fluconazole versus adjunctive 5-FC. So those are sort of 4 arms there, and then there's a all-oral arm of 5-FC and fluconazole, and so that should hopefully be finished by maybe February of next year-ish, and presented at the Crypto and Cryptococcosis International Meeting in Brazil in March. So that's one. Second funded trial that's ongoing is going to be led by Joe Jarvis and Tom Harrison, looking at, once again, a non-inferiority study of likely sort of single high-dose ambisome versus sort of the traditional 14 days of ambisome with adjunctive, probably fluconazole or 5-FC. And so that will hopefully start next year. The third trial that's ongoing is our team's study looking at adjunctive sertraline as an antifungal agent, not as an antidepressant, but as an antifungal drug. And so that is about a little over halfway enrolled and should hopefully finish by June of 2018-ish. I guess the fourth study, which is funded, which hopefully will happen, will be looking at fluconazole plus sertraline in an asymptomatic cryptococcal antigenemia population, which is a cooperative agreement. So hopefully it will happen. And then sort of other sort of potential studies for the future. So the Viamet compound is currently in phase one trials looking at PK issues and safety. There's plans for a phase 2, which might start next year. There's the second one is the Martinez, the oral amphotericin compound, which we're hoping to get in at least sort of starting some phase 1, phase 2 trials. And so those are sort of the current things on the horizon. Also alluded to was the ORCUS trial, which is another Craig screening study. There was a multi-site randomized trial in Uganda, which I don't think, Tom didn't share the results of that, but in that study with basically implementing Craig's screening, there was about a 20 to 25% reduction in all-cause mortality. So crypto certainly causes death, and so if you screen for it and prevent it, there's a benefit to the population. So other things, we talked a lot about biomarkers. I think we sort of and the role of potential biomarkers to guide therapy. I forget what the Craig assay. Oh yeah. So the comment that there's potentially semi-quantitative sort of high-low band Craig assay that's in the future, and then transplant studies we alluded to earlier on what's the role of potential screening and also just treatment, and all the treatment guidelines are really based on HIV positive people, and so should there be more studies in the transplant population and HIV negative people. And then the last one is Crypto Mag, and so this cryptococcal meningitis advocacy group, and so which was formed, and one of the things kind of I think which is relevant is that this group is which I'm part of and led by Angela Loisy from St. George's in London, is we've tried to really reach outside of the fungal community and really kind of talk about crypto at other meetings, whether it's ASM or ICAC or tropical medicine meetings, to kind of reach beyond just the fungal crowd, because one of the problems we notice as we get all the crypto people together, talk about how bad crypto is, and the same thing you could talk about candidemia, how candidemia is bad, and all the candidemia people agree with that, but reaching outside of just the mycology world to really talk about the relevant diseases to a broader audience is something that we've really tried to do, and also talking to funders and WHO and Unitate and the Clinton Health Access Initiative and MSF and a lot of other people on a sort of a global scale to talk about access to diagnostics and therapeutics. And I guess the last one was crypto guidance. Before I hand over, the other thing I'll plug is that so for opportunities, I think, so in Uganda, our team has sort of a Fogarty Fellowship and a Doris Duke Fellowship, and so these are sort of opportunities for trainees to have a funded, year-long research experience abroad. And so the Fogarty Fellowships are typically now they're for postdoctoral people, so PhDs and MDs, so fellows. They can be post residency or post their fellowship if they want to do global health for a year. And then the Doris Duke Fellowships are for basically third, fourth year med students for a year abroad. And so while our team does crypto, there's sort of broader interest in mycology in general. So if you have a trainee that wants to do something in Uganda related to fungal disease, we'd be happy to have them, and you can contact me, and perhaps we could send out the announcement for these programs maybe through the listserv or have that available. So that's another opportunity for trainees that are interested in fungal diseases.
We're just going to finish with one more thing. David let me do the crypto guidelines. So I just need a little bit of feedback here. I have the opportunity to do this. So I've been trying for over a year to get the IDSA excited about re-upping or renewing the IDSA crypto guidelines. They are about it, and I guess everybody else has got theirs, the Aspergillus, the Candida, the endemic mycosis, but crypto hasn't got that. Now, the final thing is, I think, going forward, one of the things I'll tell you, it was talked about a little bit today that we should do a position paper and various things on how to use the laboratory for fungal infections and stuff like that. And I just want to emphasize something that I think is kind of important. If you want to touch the house staff and physicians taking care of patients, we have to be creative, and I think we should actually go to UpToDate and say, can we write a chapter? Because if you can write a chapter on how to use the laboratory, and they let you have that, you'll get 100,000 hits in a year. And you will go to the place that actually, that's where they read things. So I think from a critical standpoint, we should think about whether we can actually do that.
The question is how much royalty do we get from that? 100,000 hits each. How much royalty? Is that like $50?
Actually, I hate to tell you, there's a lot of royalty.
Okay. Okay. All right. Okay. I think our next presenter will be. Where's Carol? Where's Carol Kaufman? Is Carol here? Yeah. Where's GR? Where's GR? Has he graciously agreed to do this? Okay. There we go. All right, come on. Okay. That's right. Okay. All right. And I want you to make sure that you dress casually tonight, okay?
It's cold today. This is how we always dress in Northern California. We're a little less formal. So I'd like to really thank again the speakers. We tried to really kind of expand the number of people that were new to the MSG with this, and tried to invite people that a lot of folks hadn't heard speak before. So thanks again to Dave for coming and giving sort of a nice overview of his past work in phylogenetics, and a nice update there. And thanks again to Jane, who I thought was right over here. That was really a great talk, introduction to sort of veterinary mycology for a lot of us who don't get to see that. So thanks again, and then thanks to Elon for Blasto and Amanzia, and we really look forward to sort of how this is going to be resolved over your work in the next few years. So thank you for coming as well. So the things we talked about a little bit really were this update, the NIH-sponsored treatment trial for primary coccidial pneumonia, which is antibiotics versus antibiotics plus fluconazole. And hopefully that will finally give us at least some semblance of resolution to this question. We have a lot of concerns about that study. It's enrolling quite slowly, but still hopeful that we'll have some sort of an answer. We talked a little bit about in the symposia about the treatment of coccidioidal meningitis with combination therapy versus single. That's really impossible to do prospectively. So we've assembled this sort of large retrospective multi-center group to look at some of these aspects retrospectively, which has led to some nice studies. But this is really sort of just our data at UC Davis, so hopefully that will provide at least some guidance on the utility of combination therapy for coccidioidal meningitis. And then the Viamet study, which is still pending, that'll be a phase 2 study. So hopefully that will be really a useful drug as well that's difficult to treat endemic pathogen. Histo and Blasto, MSG14 was talked about last night, which is a posaconazole tablet for the treatment of both of those, and hopefully a few Sporothrix patients and Talaromyces possibly mixed in as well. So still discussing that and finalizing funding for that. The new itraconazole formulation, a lot of interest in that in the treatment of the endemics as well. So a group we're going to definitely approach the treatment of Histo and Blasto. Isavuconazole, we've had some discussions for the treatment of those as well as for disseminated in CNS cocci. So those discussions will remain ongoing. And then Viamet we talked about already with cocci. And then one of the other ideas that was brought up, which I do think is a good idea, is really a registry study for Histo, Blasto, and Sporo as well to try to really increase the number of patients that we could look at for a number of different treatment regimens as well as outcomes by type of disease. I think a randomized trial is really pretty difficult to do for these. Although we talked quite a bit about using surrogates, I think we have really great surrogates for outcomes for Cryptococcus, I think for Aspergillus with galactomannan, we have a pretty good outcome, a pretty good surrogate as well. I think we'd steal from the cardiologists a bit using surrogate outcomes. I mean, they use carotid intimal thickness as a surrogate outcome rather than doing mortality for all of their studies. So I think there is some precedent, and we should probably try to borrow from that a little bit and possibly even write a white paper together as a group to really push for that as an outcome to use some of these markers. Okay, so Dr. Fungus, after really our push last night, had a couple people talk about writing pages for us, so that's great. We would love as many people as we're willing to write pages. There will be thousands of pages on this site eventually, so please invite yourself or a fellow that's even not willing to do it. You can put some pressure on them to write a page for us, and then you can update it every few years. Case of the month, again, is really very straightforward. You can use your fellows' cases, write a couple paragraphs, send it to us, and we'll edit it and get it up on the site. That we anticipate that will be a really beloved forum. I think a lot of us, even that don't do a lot of tropical medicine, really enjoy the Gorgas course cases every month, just as sort of a refresher periodically. So we think that the mycology will be the same for those folks who don't do a whole lot of mycology, that they'll really enjoy those cases as well, and can continue to sort of push that on the trainees also. So please try to send cases that do have some type of photographic image, whether it's an isolate, histopathology, a picture of the patient, some radiographic image. So it's really nice to have some type of imaging that's really the focus of that. Oh, and then this is just a reminder again of the site being revamped. We kind of looked through these last night, so I won't belabor that. But really a new look for the site. A number of different aspects are really improved. We do have a Twitter page and a Facebook page that'll be sort of linked up to the site when it's all said and done too. So hopefully meetings like this in the future you can kind of follow along even remotely and see what's tweeted. So that is it for us.
Okay. Thank you. Twitter and Facebook are included in order to exclude those of us who are older than 50. Okay. But we don't take it personally, however. Okay. So our next group. Oh, and I would say before Peter and Tom come up, that one of the my thoughts about a registry, although I'd much rather see a randomized trial or at least an open label trial, but one of the nice things about a registry for histo and blasto, y'all come on up, is that if we have the isolates, we could actually start looking and tracking potentially Monsia, but also begin to see how much dermatitis and how much Gilcrestii we have, which would be, kind of news for most of us. Okay, are you going to do this alone?
Apparently, yes.
Okay, and we don't.
Sorry, Tom. Sorry? Yeah, Tom promised me that. I've been told I have to be short, sweet, and to the point. I'm going to be short, sweet, and to the point. So, yes, we had 4 very good talks. Some of them ran over time. I was thinking of every gesture except throwing my pen at the speakers. And when you're looking for coffee in a restaurant in the morning, you go, and they never see you. They always look all the. That's what the speakers were doing this morning. So I just wanted to say the chairs were not to blame, the speakers were, except for one. Tom kept to time, so thank you very much for that, Tom. But as I said, they were very good talks, and they covered what we wanted to talk about. Nathan gave a very short talk, but emphasizing resistance. I'm still skeptical about how important resistance is to clinicians, but that's my problem. You might think it's very important or not, but there is work to be done there. The talk by Rob and Tobias, I have to say, went a little bit above my head because I'm of that age now where, there is such a thing as too much information. I am totally incapable of processing it, but I think they gave talks about oxygen, about growth factors, and what have you, and you'll all remember that much better than I will. Tom gave an excellent talk about clinicians, and I noticed how he did his trick of keeping within time. He flashed the slides almost subliminally. So, and this is all to encourage you to buy his next book. But anyway, I'd like to thank all the 4 speakers. They did a nice job. So a round of applause for them. Now, I have a little thing at the end of this, by the way. It's a very short quiz, and I'm just going to test all your knowledge, so you have to be awake. Don't drink too much. But basically, we talked a lot about diagnosis. And in fact, one of the things I liked about the new approach to antimicrobial drug resistance is the emphasis placed on diagnosis. It's the first time I've seen that. It's always been on drugs and all the rest of it. Diagnosis is important. But as was emphasized, there are different types, different ways of looking at diagnosis depending on level of risk, whether you want to confirm the diagnosis, or as some cynics would say, whether you want to know what you have done and failed to do in the past. Because one of the issues that came up was how accessible are diagnostic tests. And what you were saying to me today is a message across the whole globe. It's not a unique problem to this. So these were the list of things we touched upon. Whoa, 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 whoa. Here we go. God, I'm going too fast. We talked about biorepository. It's tragic when biomaterial gets thrown away, but there are all kinds of reasons why that happens. And we talked about how to tackle this. We talked about imaging, because there are some new techniques in imaging. Tom mentioned PET scanning. It would be nice if we could PET scan things. And we talked about a very important issue of diagnostic stewardship, which includes a laboratory test formula, encouraging people to know why they're using tests, why are you ordering tests in the first place, what tests you should order, and how to manage them, under the heading of stewardship. And I think we all agreed there were 2 or 3 action points. 2 of them were to write position or white papers, whatever you want to call them, on the use of diagnostic tests for the community at large. And the other one is how to use diagnostic tests as surrogate markers for outcome for clinical trials. I think there's a broad consensus, and it's people like you that influence opinion, and that's the most important reason why these papers should be put out there, signed by as many people as possible as position papers. And then there was a whole setting up a working group on biorepository to see what can be rescued out of those samples that are at the moment freezing away down in Florida from the Aztec study and the like. Then we touched on clinical, and we all agreed that randomized controlled trials are almost all but impossible for all kinds of reasons. And we talked at the reason why you have randomized controlled trials, how they should be run, what the endpoints should be. And these are issues, again, which requires intellectual input. We will not change opinions by, one of the things I said this morning, half as a joke, is Food and Drug Administration are actually surrogates of peer review. That's the way I look at them. So it's up to us to influence them and not the other way around. They clearly have a regulatory function. We can't influence that. But the thinking about clinical trials is crucially important. Otherwise, some of those nice products we heard about last night will never, ever, ever get to the clinic. So it is important. And again, position paper is important. I really can't emphasize that enough. Obviously, I would like to say send it to my journal, but there is a wide variety of journals out there. I don't actually care as long as you get it out there. We also talked about clinical, and there's lots of them. And my worry for this group is you have a list of lots of cherries which you'd like to pick. But I'm afraid you're going to have to choose which ones you're going to pick. Because you need people. I estimate for every 10 people, 1 of them will work. 2 of them could be persuaded to work, and the other 7 will tell them how they should work. That's the reality. Yeah, you're all laughing, but it is true. So basically, you have to pick the cherry. And there are lots of cherries here, ranging from precision medicine all the way up to lung transplants. Some are easier than others. And then the current concerns are generally similar for them all. Data, large centers, who does it, how you recruit centers, etc. Making use of data that already exists. There's a big business at the moment with meta-analysis where people are doing patient-based meta-analysis. So, they do exist, and where possible, pool your resources. Now then, I'm going to make you all work, because we all talked about diagnostics, but I'm guaranteeing none of you know really enough about the mechanics of diagnostics. I know I don't. And we talked about sensitivity and specificity. You're all looking quite blank. Do we know what sensitivity and specificity are? Yes, you do. Okay. So this is a test I like to do to test your knowledge and my own knowledge. I'm choosing galactomannan because it's easy, something I know something about. Galactomannan is detected in a serum sample from this patient. Stem cell transplant, myeloablative conditioning, Risk in the center is 5%. Sensitivity is 90%. Specificity is 80%. Question. What's the chance this patient actually has invasive aspergillosis? How many of you think it's 10%? Don't be shy. 20%. Look at that, look at that. Okay, 80%. Okay. 95%. And the rest of you don't know. Is that true? You don't know? Okay. The correct answer is 20%. Pete, I saw you putting your hand. You got it right, didn't you? Yeah, okay. The point being is we're now, you know that 2x2 table is very, very deceptive. Because one way of looking at it is you're looking at it from the test point of view. The other way is, what do you do when you get an answer? Does this patient have the disease or not? And actually it's deceptively, there's a whole book written about this, by the way, if you're interested, by a guy called Guggenheimer. Brilliant book. It's about risk, uncertainty and all the rest of it. But in fact, he gives you a clue. The answer is 20%. And when I asked this to experts before, you can see that only 1 in 4 experts got the answer right. And some of those experts were actually on the panel that judged for the Food and Drug Administration for passing the test in the first place. So I thought to myself, okay, this is what you actually do. I'll show you an app in a minute. Is if you follow the logic, 5%, 1,000 patients, 50 of them will have aspergillosis. The chances are with a positive test, actually, it's pretty good that some of them will be truly positive, but some of them will actually be falsely positive, given that sensitivity and specificity. And in fact, most of the positive tests are actually false positives. Okay? There you go. So the answer is 1 in 5. So what it's telling us, psychologically, we'd love to believe every positive test result, but in fact, we're deceiving ourselves most of the time in low prevalence diseases. Turning around the other way, this should be easier now. Galactoman is not detected in any sample from this patient. The same sensitivity and specificity as before and the same prevalence. So what is the chance he doesn't have disease? This touches on a discussion you were having earlier on today. Is it 10% he doesn't have the disease? Don't be shy. I'll start at the other end then. Is it 99% chance he doesn't have a disease? 1, 2, 3, 4, 5, 6. Okay. Is it 95%? There you go. Is it 80%? Is it less than 80%? Marcus, you didn't answer that. Oh. You're fired. The correct answer is 99%. Now, most of you clearly don't believe that. And that's one of the problems we have with diagnostic tests. How do you convince someone that a negative answer really is negative and they don't need to treat? Or if they're treating, they can stop treating. That's where the battle is going to be. And again, that's where white papers should come. So you see, in this case, the experts regressed to the mean. And in fact, 57% of them got it wrong. And again, it's the same type of logic. You can actually see that it's almost 100%. And most people go, oh, it's so difficult to accept a negative result. Where's a positive result? They go flying off everywhere. Yeah, absolutely. But you know, yeah, absolutely, you're absolutely right. The negative predictive value is going to be, is going to be high anyway. I know. Why do the test? I know. Okay. There is an app freely available. There's a version 2 coming out anytime this week. I recommend you play with it because it gives you different ways of acclimatizing yourself to this thinking. It's free for Android. It's free for Android, yes, Android. But for those iPhone users, it's much better. Thank you very much.
Well, that went a little different direction than I thought it would go. That's always the risk with Donnelly. All right. Okay. My friend Luis is going to wrap it up, and then I'm going to make some closing comments, and then we'll be done. Thank you, Luis.
So I'd like to start by thanking the father-to-be who is going to be in deep trouble for taking time off and talking to people when his wife is going to have a baby tomorrow. Mahmoud gave us an excellent overview of the microbiome, and really started a very good discussion that continued into the second part of the section. Jack Edwards brought us the latest on vaccines and where we're going there. And Theo gave us a big brush on pediatric epidemiology. And Tom Chiller scared us to death and really gave us a reason to live with Candida auris. So in the discussion, we really talked about Candida auris and that we really need to take this and run with it, increase awareness, do advocacy, and this is really our opportunity to be in the limelight. Hopefully, Angelina is going to get Candida auris, not Brad Pitt, and it'll be disease of the month for somebody. We did talk about the natural history of echinocandin failures as a possible registry study we want to go and find funding for with our pharma friends and some of the foundations as well. We did talk about collecting more than just clinical information, but serum, isolates, and doing some very detailed work there. And we did want to see what the combination of multiple infections is going to be looking like. The MRSA story, there's Pseudomonas data. We do want to study this fungal bacterial interface in detail. Joe Vasquez talked to us about his modeling work. We want to see the preliminary results, and of course, this can be a natural study for MSG where we want to validate the scores prospectively. Tanya talked to us about high, intermediate, and low risk stratification, which we'll consider with Joe's data. Again, we want to participate in the vaccine development, and I hope I got the message through that creating a protocol at this stage is going to be an asset for Novodyne. It'll add it to its portfolio when they want to sell to that unnamed pharmaceutical company that starts with a P. And the treatment and strategic studies, we do want to see co-infected patients, intermittent macrofungi studies. Frankie mentioned the need for an official study in endocarditis, although this is most likely to be challenging to get funded, but this can be done nevertheless. And we do want to do some open label studies looking at difficult situations like implanted catheters and doing some translational research in those studies. Diagnostics and stewardship are tied together. We do need to work on new stewardship strategies, starting antimicrobials, or stopping them, just really going with what Pete just showed us. And I think there's an opportunity to do this with the recent mandates to do stewardship in general for the hospitals. And we do want to kind of get a paper out there talking about this antifungals and stewardship, taking the idea of all the use that is being basically rolled out unnecessarily throughout hospitals in the United States. Before I turn it over to Pete, I'd like to recognize that we have people from almost every continent visiting us today. There's some people that travel very far and wide. We have people from Mexico, Central America, Latin America, a lot of people from Europe, Australia, some honorary people from Africa, and I hope this continues to be an international group, and we want to thank you for taking the time to travel all the way to California.
Thank you. Okay. All right, done with slides. I'm going to make a few comments and closing remarks, and then we'll just adjourn. So, yeah. Right. Yeah. I'm going to get to that right now. Okay. So, the logical next question is where do we go? Where do we go from here? This is a great kickstart, and so what do we do with all this information? What you just ran through literally was all the ideas that were thrown up, plus many more. There are many, many more. What I would like to see us do, and the way to follow up on these ideas, I mean, some have legs already. Some will grow on their own. Some are halfway there. But the way this grows is that we reconvene as subgroups, working groups. I mean, in the past, the MSG was 30 people who came together at NIH, and we sat around a table and we hashed out things. We actually worked out protocols. You can't do that with this number of people. And so what you're trying to do is filter a lot of ideas, and then we after having stewed on them for a little bit, come back together, the subgroups, the people who are really interested in working on, for instance, crypto or the endemics or Canada or the aspergillus projects, and get involved. And so you get involved, and we will arrange times that we'll either meet face-to-face or by phone, and we can spend time going over these specifics. What's really feasible? Who's going to do it? Who's going to fund it? Does it need funding? And this is how you all get and remain involved. I mean, there are many, many ways to be involved with this group, but to be involved in the actual conduct of studies, that's how we do. And so I would see that as happening. And so I think the natural thing that's likely to happen is that we'll probably arrange a 2 or 3 hour window during ID week where 1 or 2 of these subgroups can come together and we can hash out some of these ideas. We'll be in communication with everybody prior to that time. Now, relative to Richard's question, we anticipated that everything that we've gone over will be both recorded, the slides will be available, including these slides, and so we have a record of it. So that will be, I guess we haven't figured out exactly where we're going to post it, but presumably we'll post it on our website in the very near future, and that will be preceded by an email, a message telling you where this is going to show up. But this will not be lost. It'll be archived and ready for, prepared there for posterity. So any questions about that? So my next comment is to the young investigators, and please don't be shy. Those who are investigators that are either fellows or junior faculty who've never been here before, raise your hand. I think there are about 10 of you. Great, that's terrific. Okay, so the way, the way all of us got started was somebody helped us. Somebody opened doors for us. I mean, we all benefited from somebody else's goodness, if you will, or just their goodwill. They wanted to bring us on along. But you also have to make the first step. And so the way you do that is you just speak up. You raise your hand. You volunteer for one of these committees. You're not likely to be elected to a position because nobody knows who the hell you are right now. But they will, they really will. They really will. The more you're out there and show your eagerness and your enthusiasm, this is how it's done, at least in this group. And so you will find a lot of people here ready and willing to help you. And hopefully you've had a chance to meet a lot of these people. I'm a little disappointed that we didn't have more. I was telling our board this morning, I sent a letter to every division director in the country asking them to send a junior faculty or a fellow. Some of you may be here because of that, but it probably just went into junk mail. Here's another one from Pappas. Who is he? But I would really encourage you to do that. I think that's incredibly important to you as your careers if you choose to do this. And I think that this is I think this is a perfectly viable career. You've heard us talk very honestly about the difficulties of funding, but there are also lots of opportunities and lots of really, really good people in this crowd that I think if you get to know them, you'll really grow to love this group of folks. So it's a good place to be, and I would strongly encourage you to reach out to these people like some of you have already done. I too want to thank the people, especially those who came from far away. We had a group of speakers that, in my view, was just phenomenal. We did something very different this year. We reached out and got people who kindly agreed to come and join us and to offer to this group. I think it's really helped increase our depth tremendously, and I hope you continue to remain engaged. We certainly will want to engage you, but I'm not going to name you individually, but I want to thank you for coming, and I really want to thank the people who came from such a long way. Our Australian contingent, extraordinarily impressive. Want to thank Castellan and Associates. You guys did a great job. And I've already got one referral for you. No, you did a really nice job, and we're invisible, really invisible, but just completely. I've never worked with a group where things ran so smoothly, except when we tried to compress 10 presentations into 45 minutes last night. I thought that was interesting, but that was mostly my fault. What else? Carolyn. We wouldn't be a corporation. We probably wouldn't have this meeting had Carolyn not agreed to come back to the fold. She left us many years ago. She left me for another man, but she's come back finally. And it's been just such a nice infusion of energy and ideas to have Carolyn kind of back with us. It's really, really been a blessing. I hope all of you appreciate it like I do. So, Carolyn, thank you. Okay, and then finally, those who are with industry, especially the sponsors, if you could just, after we adjourn, if you could just stay here just for a few minutes. I want to get some verbal feedback from you. Everybody who attended will be getting a request for feedback. And we really need feedback in order to plan the next meeting in 2 years. And be frank, really be frank, and just tell us what you liked, what you didn't like, how we need to make this a better meeting. I will say that I was glad that we capped out at about 125. I'm not sure how much bigger you can get and have a working meeting, but we'll see. We'll see how this goes. But I do want your honest feedback. So all the participants, I need your, just written feedback. Give us a score. Give us a grade, if you will, and let us know how you did. For those who are sponsors, I want to talk to you directly and just kind of get your feedback now, and then I'll get it later, I'm sure. We will start fundraising for 2018 very soon. So you can expect that we'll be coming back at you very, very soon. Let's see. Heron, if you'll stay too, then we can get together. And let's see, is there anything else? Any other? Yeah. Mahmoud.
I really want to express how much I enjoyed this meeting.
Here, speak into the microphone.
How much I enjoyed this meeting, and I really want to take this opportunity for all of us to thank Peter for what he did. In a way, really, because of what you did, I personally feel so excited. I'm usually an excitable guy anyway, but really this meeting was beautiful, lovely, and also it gave this opportunity for us to meet everybody and talk. And I tell you, the effort and the amount of energy you put for this is tremendous, and we really appreciate it. And in a way, it raised on me the good old days where we used to have focus on fungal infection, and we meet all these people. And this coming to this meeting gave me this feeling, and it's all due to your capability. And thank you again.
Oh, thank you, thank you. That's not. Well, that's not really true, but I appreciate you coming. It's the people who need to be thanked are our board, our board and our steering committee who've really been helpful all along. I didn't thank the program committee, but they were enormously helpful as well. I know that there's somebody else I'm forgetting to mention, but I can't remember. It's problem being 64. Okay. Yeah, and somebody's going to say Twitter, and I'm going to say, what the hell is Twitter? Okay. Well, again, if we could just make certain that the sponsors or some representative from the sponsors stay in here after we adjourn, I'd like to get some feedback from you. For everybody else, thank you. Tomorrow morning is free. I don't know, there's nothing scheduled. I'm leaving at 8. But tomorrow morning is, it's free. It's actually, it was meant really to be, if anybody wanted to meet offline, if they just kind of wanted to get together in groups, that'd be perfectly fine. I'll be up at 6. If anybody wants to meet in the lobby, we can talk about anything you'd like. But anyway, thank you. Have a good evening. Roll Tide.